Hey there, everyone. Dr. Maxfield DeCarlo here. I'm going to share my screen with you. And here is our lecture. Talk about physician-assisted death or death with dignity. So here's the thing, is that as we're having this conversation, obviously there's a lot of debate going on and continuing to go on across the country with lots of different states trying to make decisions on physician-assisted suicide, more specifically, death with dignity, and creating laws to protect physicians and families that decide that they want their patient, or the patient decides that they want to be in control of how and when they die. So interestingly enough, it's important for us to remember what we're actually talking about, okay? There's been a ton of different terms that have been used to understand this. So it's important for us to kind of look at the terms that are currently being used. So let's talk just a little bit about this idea of euthanasia. Euthanasia is when a physician or someone else is assisting a patient in dying. They're actually actively helping the patient die, okay? That is not what we're talking about when we talk about with Death with Dignity Act. This would be considered what Jack Kevorkian, if you haven't seen the movie, you don't know Jack. It is a phenomenal movie. It's got Al Pacino in it, and it is just awesome. So I would suggest you watch it. But anyway, this Jack Kevorkian, the reason that he got into trouble was that it wasn't just that he was giving the patients a medication that they could take in order for them to die. He was actually administering the medication. So that moves from assisted death into actual euthanasia. So when we are talking about euthanasia, that is always when the physician is intentionally ending a patient's life, even if it's at the patient's request. The physician cannot be the one to administer the medication or anything like that. The patient has to be the one to do that. So that's sort of where we draw the line between euthanasia and death with dignity, is that the patient has to be able to take medication. This is an interesting idea, though, because when we talk about folks who are willing and wanting to take a medication to end their life, they are in the states that this is legal. They have to be in a place that they're able to actually do it. So folks who, for instance, have ALS, as they progress through their illness, oftentimes they lose the ability to swallow. And as soon as they lose that ability to swallow, they lose their ability to be able to use any Death with Dignity Act to end their life, because then it would have to be administered in a different way, which would require like an IV or something like that, which would require that the physician step in to assist the patient and actually administer the drug, and then that would be considered euthanasia, so it can't happen. So really important distinction. When we look across the world, euthanasia, where the physician actually is the one administering the medication, is actually legal in the Netherlands, Luxembourg, Belgium, Colombia, and Canada. It's not legal anywhere in the United States or other countries. So important to just know that distinction. Indirect or passive euthanasia would be something that is what happens all the time. We withdraw treatment, people are on a ventilator, and maybe we stop treatment because it's futile. Or there's what is called the double effect. And this is an interesting one, because with the double effect, that means that we might be treating someone's pain. And in order to get them out of pain, we might administer a lethal dose of a pain medicine, a narcotic, which we know could potentially stop their breathing or stop their heart, but we administer that with the hopes of reducing their pain, knowing that the side effect could be that they die. This is interesting because that is not illegal. Okay, but this double effect. There was a research study not that long ago that looked at physicians and nurses, and it was some percentage, like 80% of nurses and physicians have said that they have administered a pain medication knowing that it would end the person's life because the person had requested and wanted to die, and they were trying to get them out of pain and administered a dose that they knew would stop their breathing. 80%. Interesting, right? So although we're having this discussion about sort of the right to die and death with dignity, and there is no law in the state of Maryland to protect physicians and families, that doesn't mean that it's not happening. It's just happening under this sort of double effect. Well, I'm trying to manage your pain, and that could in fact hasten your death. So euthanasia is really not what we're talking about ever when we're talking about death with dignity. We started out this conversation years ago with the idea of physician-assisted suicide. And so we've come a long way because just that name has a stigma with the idea of suicide, people taking their own life. There's just a mental health overtone to that. And many of the folks that are choosing to end their life during a stage of terminal illness are not necessarily experiencing any mental health issue. They just really are vested in their quality of life. So all of that to just say that that it's not necessarily the case. So they've moved away from that physician-assisted suicide. And then we moved on to the term physician-assisted death and dying, which was certainly less value-laden, but also sort of gave a little bit of the wrong idea that physicians were, they are providing the prescription, but that they were actually doing something in the administration of that, which is not the case. So we have the term medical aid in death and dying. And really across the nation, we've sort of leveled out at this term of death with dignity. And many of the laws that are created are under this Death with Dignity Act. Okay, so what is required if someone wants to end their life at the end of life, if they have a terminal illness? What is required? Well, first off, you have to live in a state that has a law that protects people from having any legal ramification if they provide you a prescription. But you have to have a terminal diagnosis. In every single state that has approved a death with dignity law, they have to have a terminal diagnosis. So interestingly enough, like 90% of people who use the death with dignity law to obtain a prescription for medication are also on hospice. So you have to have a terminal diagnosis, 6 months or less to live, the same requirement as hospice in that there's a terminal diagnosis that's 6 months or less to live. You have to request the prescription both orally and in writing. So you can't just walk in one day and be like, you know what, I'm so frustrated with this disease, I want to die today. Just give me the prescription. There's a huge, long waiting period. Oftentimes it's like a 60 to 90 day waiting period to even get the prescription. So because of that, this is a long process that people have to go through in order to obtain this. 2 physicians have to certify that the person is indeed terminally ill. Just like in hospice, where it's just one, but in this case, 2 physicians have to see the patient and say they are terminally ill. they have to have, it's 2 oral requests and 1 written request. And then there's a waiting period. Like I said, there's like a 60 to 90 day waiting period. So this is an interesting sort of phenomena, especially because when we think about the folks who are coming into hospice, and a huge percentage of those people are dying within 4 to 5 days of being there, within a week. This would not work for those folks because there would be a lot of planning that has to happen way before that, the week before they would die, in order to be able to meet the waiting period, make 2 oral requests, have a written request, and all of that. So what happens with this is that after you've gone through all of those requirements in a state, and we're going to talk about which states have this law, is that then you would be given a prescription. And the prescription is for an elixir. Sometimes they have it in a powder form that you would then mix with juice. But basically what it is a barbiturate with pain medication that is going to stop your heart. If everything goes the way it's supposed to, the patient would take that medication, and within a half hour to an hour, the patient just stops breathing. It's painless because they've got the pain medication on board, and it's very peaceful, and it just stops their heart. So if there are no sort of hiccups with that, that's how it happens. We'll see later on that sometimes there's some issues with that. Interestingly enough, the cost here is in 2012, it was about $500 to get the elixir. And then after 2012, there was this huge spike from the pharmaceutical companies, and the medication went up to between $15,000 and $20,000. So people would have to request this medication, and then if they wanted to be allowed to die on their own terms, they would have to pay for this prescription. Insurance company's not going to pay for it. So you would have to pay $20,000 to die. Can you imagine? This is kind of an interesting piece in that there's been some research as well, and really more like exposure of the pharmaceutical companies that are making these medications so costly that the government has started getting some of the medication from folks who are on death row, and started getting some of those medications from folks or from the black market because the medication costs so much, and pharmaceutical companies have jacked the price up so much that our own government has turned to the black market to buy some of the medications to end people's life for folks who are on death row and sentenced to execution. So it's just an interesting piece of that. You can go to other states or other countries rather and get this medication on very cheap. But more recently, this elixir has come in a powder form that can be mixed with like juice or water, and the price has come back down to about $400 or $500, which still is a huge amount of money. So you think about who can actually afford to have this right, is a whole nother issue of debate. Okay, I'm going to skip over that and just kind of go to the states here. In 1997, the Supreme Court ruled that it is not a constitutional right to be able to take your own life in the presence of a terminal illness, and that each state had to decide whether or not that they were going to legalize this death with dignity. So in 1997, shortly thereafter, Oregon was the first state to pass a death with dignity law that again, allows physicians to write a prescription that the patient then takes on their own. Again, most of these folks are in hospice already, and the way it works is that the patient would go through the process, get the elixir, and then usually when they choose to take it, it's very planned out. It's not like someone wakes up one morning and is like, okay, that's it, and takes the medicine. Usually they plan a day, they get people together, they do something that's meaningful for them, and then the hospice nurse or physician would come and be there with the family and the patient as the family takes the medication, and then walk through the process with them. So one of the reasons for that is that if something were to go wrong, the nurse or the physician would be right there. If for some reason, at that point, the physician had to administer something if something went wrong, in these states, the physician would be covered and would not have any legal issues with helping the person die. So Oregon was the first state. Here's also very kind of unintended result of all of this is that as of January 2017, now remember that this has been going on for 20 years at this point, right? Oregon has had this law for 20 years. There has only been 1,749 prescriptions written. And of those that were written, only 1,127 people have died by actually taking the elixir. So in 20 years, that's how many people we're talking about. So when this law was passed, there was a lot of debate and concern that people were going to abuse this and everybody was just going to want to die, and people were coming from other states and they were going to try to declare residency and they were going to die. And what we found was that people are coming in asking for this elixir, getting the prescription if they actually even follow through. Sometimes people are just like, hey, like it helps me to know that I have the choice to do this if I wanted to or not. Then some folks would actually get the elixir, and once they got it, just keep it and then decide, no, you know what, I'm gonna just die naturally. It's interesting because oftentimes we see that people, they have the choice to take the medication to die, and it really strengthens their will to live because they know they can stay in control. So Oregon kind of led the way here with this. Then shortly thereafter, in 2009, Washington State came on board. Again, since 2009, only 938 prescriptions have been written, and of those, 917 deaths have been reported. In 2013, Vermont came on board, and look at these numbers, right? By June of 2017, only 53 prescriptions had been written. In 5 years, 53 prescriptions had been written. And there wasn't data on how many had been used. Montana, they're an interesting state because although they do not have a Death with Dignity Act, they have said that they will not, they have no law, but they will not prosecute any physician who assists a patient in dying. So they have protection under the law, despite the fact that there's not an actual Death with Dignity law there in Montana. California and Colorado came on board with a Death with Dignity law in 2016. The thing to remember here is that even though a state may have a Death with Dignity law in place, California was defending their law this year, and it was almost repealed, but they were successful in defending to keep the law the way it is so that Californians can take their life if they go through this process. Okay. In 2017, the District of Columbia, DC, passed their first Death with Dignity law. And then last year, Hawaii passed the law. And just recently, it was last month, New Jersey came on board and has passed the death with dignity law. So why is this such a huge debate? Well, there are certain ethical concerns, right? As social workers, we're always saying how important it is that people have the autonomy and ability to choose what they're doing. They get to choose whether or not they want to die. But yet, on the other hand, even in the presence of making that choice, we say, no, you can't choose to injure yourself or kill yourself or kill anyone else. So, when we think about people being allowed at their end of life to take their own life, if we're a clinician and we're out in the field and we have someone who's perfectly healthy who says that they're going to take their life, we immediately emergency petition them to the hospital, right? But at end of life, it's a little bit different. And so this is the, sort of the sanctity of life is what becomes called into question. We oftentimes, right, will talk about people's well-being and their quality of life. What is more important, their quality of life or to extend their life? We bring in the argument of what if we can't adequately care for people and manage their pain and their suffering at end of life? Interestingly enough, from what the research shows, that we are pretty good at that. Especially hospice is pretty good at that. So that really becomes null and void, but it's an argument that comes up. There's also always the argument about, is this death with dignity any different than withdrawing treatment when it's medically futile? So something that always comes up is just that this is really no different than withdrawing treatment, a ventilator or pressors to keep someone's heart going, that kind of thing. But there's a concern, particularly with vulnerable populations. This is a slippery slope, right? Like when we say that only folks who qualify for as being terminally ill are allowed to use this. And that is the law across the nation. Every state that has a law, it is only for terminally ill. But who's to say that someone who has a mental illness, who, say is bipolar and is just not wanting to continue to have to work through all of the ramifications of their mental illness and then would like to take their life because of that. So there's a concern that there'd be a slippery slope. There's also a concern about coercion where someone might say, I don't really want to die, but my family just want to take care of me. Or in the situation where you have someone who's disabled and dependent on their parents are getting older, and where are they going to go? They're going to say, well, they'll be so distressed if they go somewhere else. I've always taken care of them. There's this fear, this inherent fear that we would use this elixir and this law inappropriately and people's lives would be taken. Now, here's the interesting part is when we look at the research on what's happening in states that have passed these laws, we're not seeing that happening. We're not seeing that happening at all. Okay. So who actually uses physician-assisted death or death with dignity? 78% of folks are cancer patients. 8.3 were folks who had ALS. This is all based on in Oregon because it's where we have the biggest amount of data. 94% of folks died at home, and 90%, like I mentioned before, were in hospice. When we look at who is actually using this, you find that the major reasons for using the elixir and getting the elixir include folks who are saying that they were really concerned about their loss of autonomy, that they were concerned about their inability to engage in enjoyable activities and really live life to the fullest, and that they would rather die before they lost all of their autonomy or before they couldn't do any activities. Loss of dignity, inadequate pain control, which again is not something that we're actually seeing validated in the research. Concerns about being a burden. And again, here's the interesting piece, is that this idea that folks will choose to die because they're depressed. Because of course, why wouldn't they be depressed at end of life? Which we know is not the case, is that not everybody who's dying is depressed. Not everybody who is dying is feeling hopeless. So that has not been validated at all. So what have we learned from Oregon? In 17 years, there's not all that many people who have actually gotten the prescription, and 30% is the highest usage we've seen of places when they've gotten the prescription and they've actually used it. There are those complications, which I was mentioning before. Sometimes not everybody dies. Sometimes folks can vomit the prescription. And so then there's a question of how much medication they actually got. And sometimes there's an extended length of time that it takes. So if you haven't seen the movie How to Die in Oregon, there's a good example of this. The woman took the medication and like 5-6 hours later, she still hadn't died. And so it was traumatic for her family to be able to watch this and to kind of expect that she was going to die right away and that not happen. So 18% of folks who actually take the medication and the elixir end up having to have a physician intervene in order to help them die. And at that point, they may not be conscious. And so the physician has to take active measures, which then again converts it to euthanasia, which is why the law is so important, because then it protects those physicians. The other piece of this too that I just want to mention about how important it is for families to be able to rest on this law is because if you take your life, even in the presence of a terminal illness, your life insurance is null and void. So if there's an act in your state, then you actually get to keep your life insurance. Whereas if you do this on your own, then or you don't have this in your state, then you actually would, your family would lose their life insurance policy. Okay, so I'm going to stop for just a moment, and I'm going to post a video that I want you to watch too. It's only about 13 minutes long, and then I'll come back.